for all of you to feel like you had a shared mental model for approaching patients with COVID at the UW. And so we have one other lecture that Ken usually gives that we're going to share with you in August, and I'll let you know when that'll be. I do have the recording going. Thank you for the reminder. Take it away, Seth.
Okay, well, thank you so much for having me. I'm having trouble advancing my screen.
Are you sharing?
I'm sharing. My keyboard is totally locked. Are you able to?
Nope. But why don't you stop sharing? Because I made you a co-host. I wonder if that has something to do with it. Why don't you stop sharing and reshare? Can you do that?
Yep. Let me try.
And otherwise, I'll share from my computer and we can just swap.
Okay, can you see that?
Yep.
Okay, super. All right. Well, again, thank you so much for having me. I'm Seth Cohen. I'm the medical director for infection prevention. And, I'll just say it's really an infection prevention talk. This is not an infectious disease talk, even though I love talking about infectious diseases. And if anybody wants to talk more about ID, I'd be delighted to do so at any time. But this is really about how to keep you, your patients, and your family safe. This is mostly going to be a case-based talk. I'm not doing poll everywhere just because there's information that I want to get to, but also at the end I want to save time for some discussion and Q&A. So Gabby, thank you for monitoring the chat, and just let me know as things come up. And I just wanted to reinforce that we really have your back. We are in this together, and we are only going to get through the next 6 months, 12 months if we do it together. I do unfortunately think this is going to be a bit of a slog. We are all going to have rough days, rough months, rough rotations. You all are incredible. We are so lucky to have you as the house staff. And I also just want to put in a quick plug that, a lot of the other services and workers in our hospitals and clinics, including our nurses, our CNAs, our environmental services staff, they are all stressed during this time. And it means so much to them if you're able to recognize them and share gratitude with them and appreciate them. So just something to keep in mind as you're interacting with other interprofessional colleagues. Okay. So again, thank you for being flexible. Thank you for caring for each other and yourselves. And thank you for what you're about to do this year. I would say change is the only constant, and that is okay. Policies change, PPE changes, and our science changes.
I think I'll be able to see everyone after this before we round.
And I'll just thank you, and I'll just remind everybody to mute themselves if you don't mind. I would say when we think about policies, everything really comes down to what is the science and what is the biology. And then we think about what are the impacts on the people involved, how does this impact supply chain? We often have to push things through unions. And I realize that every policy change that we make has ripples of anxiety that continue to propagate out. So I realize that just even in the last few months, we are always asking people to do more, to wear more. And I realize that this in itself is a sort of source of stress. So thank you again for being so flexible with that. And then I think it's just important to remember that there's a lot that we don't know. And so there still may be many changes ahead. There are two important bookmarks that I want to make sure that everybody knows about. The first is just the homepage for our UW Medicine policies. They are all organized in one place. As you know, this is not a perfect page. A lot of our policies were written very hastily over the span of a few weeks. They are on a SharePoint site, which as an IT platform is not ideal. And we are really trying to catch up now, trying to make it a little more user-friendly, make it searchable so that you can find what's relevant for you quickly. But for now, this is really where everything is. If you see things that are outdated, let us know. But there's a lot of work going into revamping this page. And then the other critically important bookmark to have is how to get tested. And so we now have a one-stop landing page for both employee serology and PCR testing. So this is where you would go if you have symptoms and you want to get tested, or if employee health or public health tells you that as part of contact tracing, we'd like you to get tested. You just fill out the survey. Serology testing is ongoing. It will likely go on hiatus at the end of August. And so if you're interested in getting your serology done, which is not mandatory by any means, but it is confidential and it's free and something that the UW is covering for you, I would say try to get it in the next few weeks. Okay, so let's start with a case. Your pager goes off and patient KS is being admitted to your team from the emergency department. Patient KS is a middle-aged man who developed fever, cough, and shortness of breath over the past few days. He has not had diarrhea. His temperature is 39, he's tachycardic. Blood pressure is a little high, but in the normal range for an inpatient, setting 85% on room air. Chest X-ray shows bilateral opacities. So the question is, which of the following is the most appropriate next step to order? Do you want to order the rapid COVID NP swab, the standard COVID NP swab, COVID antibody, viral culture, or a COVID rapid antigen? And I'll just ask everybody to some of these may feel like softball questions, but just to generate participation, please just type your answer into the into the chat. And we'll take full answers. We'll take A, B, C, D, E. And Gabby can tell me what people are saying.
You're getting overwhelmingly A's.
Okay, great.
B from a group.
Yep, great, I love it.
Actually, couple B's, mostly A.
Okay, super. So it turns out, I think both of those are probably correct, and it really depends on what hospital you're at. I would have said probably the rapid COVID swab if available, but it turns out, and we'll get into this, that Harborview, because of some of the demands for pre-procedural testing, really has limited access to rapid testing. And so at Harborview, you may see more standard tests being ordered in this setting. But I really want to emphasize that the virology lab is truly amazing and is one of the true success stories of our fight against COVID in Washington State. And as you may know, the lab is now processing thousands of samples, up to 5,000, 6,000 samples a day. And part of that, it's a very small fraction that's actually samples from UW patients. The vast majority, it has really become the default state reference lab, and they're testing all of the nursing home patients and all of the other mobile testing that's happening in the state. And so there's a tremendous demand on the lab for test throughput. So there are really two tests that we have available. There's the rapid test and the standard test. The standard test has taken anywhere between 6 to 10 hours to come back. And again, it really depends on lab capacity. I'd say a month ago, we were much closer to that 6 to 8 hour mark. More recently, due to increased demands for public health testing, that turnaround time has lengthened a little bit. There is no trade-off in sensitivity or specificity. Both of these tests are excellent. And when you read about COVID testing and you read about CDC recommendations for testing, there's a lot of hedging in terms of, thinking about could things be falsely positive or not. And our lab really distinguishes itself in that we have a high negative predictive value. And so in general, you can often believe a negative test. Now, granted, there are, of course, situations where you have such a high pretest probability that maybe one negative test does not rule somebody out for COVID. But in the vast majority of situations, and particularly pre-procedural testing, we really do trust one negative test. The rapid test is run in batches. So they run them in a batch of 8. So if you miss that 2-hour cutoff, they can't just plug in that next test and have it run immediately. They have to wait till that next batch is done and then put the subsequent test on. And that's sometimes why that rapid test, even though we say it takes 75 minutes, can end up actually taking a few hours. The other challenge is, this is one instrument. It's susceptible to, the reagents that we have. One machine is broken at Northwest right now, and so we really don't have access to rapid testing. So there are times when we're going to have to be flexible and use one test rather than the other. But in general, especially at Montlake, if you can spare somebody PPE, or if there's an emergent situation, a rapid test is a great way to go. Similarly at Harborview, if it's really an emergency, there should be a rapid test that's available. Now, it pains me to say that for the rapid testing, it is still paper-based. It's crazy that we're still doing paper-based testing. A lot of this is site-dependent, and some of these workflows may change. But for now, this is something that the lab would like to do. So at Montlake, you just call the clinical microlab, and the lab will tube a paper requisition, an old-fashioned paper requisition, to the nursing station. At Harborview, it's a little more convoluted and actually depends on where you are in the hospital. I would say for most people in this conference, you're either going to be talking to the ED charge nurse or the lead trained observer. And I would just say, when you go to your site, hopefully your chief resident can help orient you, or you can call infection prevention during daytime hours, please. But almost all the up-to-date information is found on our intranet pages. Either go to UWMC or HMC intranet pages under infection control and COVID, and both should have rapid testing information there. Okay. So just a couple pearls about COVID testing. Just remember that putting your primary care hat on, there are a lot of suggestions about when patients should get tested as an outpatient. And there are a lot of documents that say 72 hours, and some people have taken this very, very literally. I would just say, please encourage people to be flexible, and within 3 days is perfectly fine if their procedure. It's not like Cinderella. If you have a test at 74 hours, it doesn't suddenly expire. We would be happy to accept a test at that point. And the CDC, in fact, says anytime between 72 and 96 hours would be perfectly fine. So it's good to encourage some flexibility, particularly in the PACU and with the charge nurses and procedural areas. And then just another issue to bring up is that inconclusive tests, we used to see them much more commonly earlier on in the epidemic, and they have been less common. What an inconclusive test means is that when we run the PCR, there are actually 2 gene targets that our tests look for. And an inconclusive test means that one gene was detected, but the other one was not detected. And so for that reason, we typically treat inconclusive tests as positive, but we have seen times when there's really been a compelling reason to suggest that somebody, this is a false positive, or it's not real. And that really is scenario specific, and it's good to talk to ID or infection prevention if you're really thinking about not treating it as a real positive. But contamination is possible, and sometimes we can just get a tiny piece of a viral particle that can land on a swab that's in the lab and contaminate it, and sometimes produce an inconclusive test. But clinically, we'd rather treat it as a positive until proven otherwise. So the pearls for testing that I really want to make sure that everybody understands are that people can shed non-viable virus for weeks to months. And this is generally not clinically meaningful. And that's relevant because our strategy as a system to this point has been very heavily based on testing. And we test too much. And we're detecting a lot of people who are just shedding virus. But a lot of these people who have positive PCRs are not infectious. So we'll just keep that in mind when we think about exposure policies and think about precautions. Okay, so getting back to your patient, the testing is pending. What precautions would you like to order on this symptomatic patient? And the answers, the choices are standard, droplet contact, special droplet contact, or airborne. So, Gabby, are you still able to look at the chat? Sorry, you're on mute.
Sorry. Yep. So you're getting a smattering of answers, mostly C, a couple B's, and a D.
Great. Okay. So that's That's perfect. So this is just to remind you, a stable symptomatic patient, bilateral chest x-rays, probably coming up to the floor. And those are all great answers to think through. I would say here the preferred answer would be special droplet contact. And so what is special droplet contact? Well, it is really our backbone PPE strategy currently. It's appropriate for PUIs or COVID positive patients who do not require aerosol generating procedures, okay? And why is it special? Why aren't we calling it just droplet contact? Well, early on we had officers who are trained observers that assist with donning and doffing. And now at most sites we don't have specific officers, but we do have nurses and others who can assist with this donning and doffing. And that's really because doffing is a particularly high-risk time for self-contamination. And even though many of us are experts now, for better or for worse, in putting on and taking off our PPE, we want to make sure that we're doing it correctly. And it's great to have somebody who can give you some feedback on that. And even if there's not a officer present, just having somebody on your team observing you as you're taking off your PPE can be incredibly helpful. And just a reminder that when you collect a COVID NP swab, even if the patient is going to be under standard precautions because you're collecting this for a peri-procedural indication or surveillance indication, these swabs can generate a strong cough reflex or a sneeze reflex, which can generate droplets. And for that reason, we collect NP swabs under droplet contact, and this applies to clinic spaces as well. Okay, so now what about airborne precautions? So airborne contact is appropriate for patients who are undergoing aerosol generating procedures, AGPs, or people who are at high risk of undergoing AGPs, and that's more of a clinical distinction. This consists of either a fit-tested N95 or a PAPR. And if you need any refreshers on PPE videos, donning and doffing, what PPE to use, the WISH site has some great videos that are posted. There are many situation-specific videos that are up there. The Harborview Intranet site also has excellent videos, and there are fewer of them, which may feel a little less overwhelming to walk through. But all of them are really well done. So the question is really, what is an aerosol generating procedure? And this turns out very difficult to define. Our UW consensus is based on CDC recommendations. As you can imagine, there are what feels like hundreds of professional societies. We have had incredible amounts of spirited departmental discussions about whether certain procedures are considered aerosol generating. And in several aerosol generating procedures, or AGPs, are not true AGPs, but we're listing them as AGP-like until we have more information. And this list really represents hundreds of hours of collective discussion between infection prevention and just about every possible department, many individuals, chairs, town halls, lengthy spirited emails, and lots of internal discussion. This list is on the COVID site. It will likely continue to change, but these are sort of a good overview of procedures that are considered AGPs. Now, I just wanted to give you an example of some of the weighty issues that we discuss in infection prevention. I have to redact some of this. I know it looks a little bit like the Mueller report, but it's to protect some people's privacy and some other inappropriate things that Paul Pottinger has typed out. But just to give you a sense of some of our discussions, where we have a full professor of medicine saying, while I agree that you can find RNA in poop, probably from swallowed saliva, I'm not convinced this means that farts are deadly. Sincerely and exhaustively, Paul Pottinger. So we have had full email chains just on whether farts are considered AGPs. So how do I choose between N95s and surgical masks? So I would just say this whole dichotomy between droplet and airborne spread is really false. And in reality, there is a clear spectrum of droplets and aerosols depending on the mechanism of exposure and what the environment is. And I think we all know that transmission risk goes up with time of contact, proximity, and really what the ventilation system is. And as many of you know, our clinical spaces have really optimized air exchanges with several HEPA filters in series and many other controls that really reduce the risk of infectious aerosols with most of our interactions in the hospital. And just to kind of drill down on this, this is something that is probably, we give it sort of a short shrift, but there's an organization called NIOSH, which is the National Institute for Occupational Safety and Health, and it defines 5 rungs of what we call the hierarchy of controls: elimination, substitution, engineering controls, administrative controls, and personal protective equipment. And this hierarchy is arranged beginning with the most effective controls and then proceeds to the least effective. And you can see that PPE is actually considered one of the least effective controls because eliminating the hazard is usually the ultimate goal, although it can be quite challenging. And I've just provided some examples of layers of controls that you can really think of this as sort of an infection prevention bundle, where it's not that we're just relying on PPE, but we're thinking about how to triage patients, how to physically distance them. For engineering controls, setting up plastic barriers, optimizing ventilation, optimizing air exchanges, creating negative pressure rooms, creating floor markers, designated COVID units and spaces. And then for administrative controls, of course, employee attestations and other things. And then for PPE, universal masking. Now we've moved to universal eye protection, face shields, hand hygiene. So all of these together help significantly mitigate the risk. And I think it's important to think about this as PPE being one piece of it, rather than the PPE debate being a completely separate issue. So I would just say, the PPE choice is really pragmatic, and we're focusing on what is the overwhelming mode of transmission in the hospital and clinics. We think about that hierarchy of controls that I just mentioned. And then, of course, we're thinking about what is our PPE supply. And early on in the epidemic, we really recognized that, PPE was scattered, and we really needed a centralized way to track all of our pieces of personal protective equipment. And so we have a whole team of supply chain folks who are working on trying to forecast what our PPE needs are going to be in the next weeks and months. And this is an important topic, and it's really a challenge that I think we face as a system and many hospitals face around the country. So a question that comes up that I think probably doesn't get answered, at least to the house staff, is what is the status of our N95 supply chain? I realize that picture sort of looks like 2 N95s mating. But anyway, incident command calls. So we have this military-like structure, which some of you may or may not be aware of, which is called an incident command here at UW, where there's an incident commander, and then there's really an org chart of people in charge of supply chain and infection prevention, logistics, planning, operations. And so we have these calls several times a week. And on these calls, the supply chain gives an update, and they say there are no material changes. And when they say there are no material changes, what they mean by that is that there's a huge supply chain that's tracking over 200 critical items and really ensuring that they're in sufficient quantities based on burn rates across all entities. So I thought I'd just give you a sense of some of the data. This is taken from one of our supply chain dashboards. And there are many ways to look at this data, but this is, for instance, this is N95s at Harborview. And this is our burn rate. This is estimates of days on hand based on our burn rate over the last 7 days. And you can look at over the last 7 days, you can look at the last 3 days. But of course, this does not take into account what exponential growth looks like. So, you can see that our supply chain is actually quite variable. And so earlier this month, we only had 8 days of N95s on hand. And then we just got a new shipment in, so that went up to 25 days. But of course, that is just reflecting our current N95 sparing and with reuse policy. And so if we were to suddenly face a surge, you can imagine these days on hand would drop precipitously. Now, the same thing is true of PAPR hoods. Earlier this month, we were down to less than a day on hand for PAPR hoods with our current strategy. Now, these bars went up only because we received a large shipment from the VA on the day that I pulled this data. But otherwise, you can see that things are very touch and go. And again, we have been promised N95 shipments that have not materialized at times. And so people are feeling very nervous about what our N95 and Packerhood supply chain could look like in the future. And I would just say the take-home point from this is that our supply chain is fragile. We have a lot of folks working on it, and they're doing a tremendous job. But that's really part of the rationale for focusing on contingency measures like conservation, extended use, and reuse policies. So should I focus on, should urgent and emergent patient care be delayed while awaiting COVID testing? And what do people think? Yes, no, or sometimes? Gabby, any answers in the chat?
Yep. Lots of B's and C's. Excuse me.
Thank you, Matthew. Oh, sorry, you're still muted.
Yep, sorry. Seth, maybe this is just also a good time to pause. I haven't seen anybody putting questions into the chat for Seth, but please, if you have questions, I know this is a lot of information, and I know Seth thought, thinking really hard about what you need to know as admitting providers. So if you have questions, please feel free to put them in the chat. I'm monitoring the chat, and I'm happy to pause Seth and have him answer questions. We can also batch those questions. I know he's saving time at the end. So just want to make sure people feel like you can ask.
Yeah, absolutely. Thanks. Okay, so I would just say all procedures can be performed under airborne precautions as needed. And if you feel like there is a delay, if you're dealing with a consultant or you need to perform a procedure, really you are empowered to advocate for your patient so that care is not delayed when waiting for a test. And we've had, unfortunately, several adverse outcomes when patients, are waiting for a procedure and there's a delay in getting that COVID test. So I would say if the patient needs to go for a procedure, they got to do it, and you can do it under airborne. That is okay. I'm going to change gears a little bit and talk a little bit about employee health and what we know about your health and caring for patients with COVID. So we'll start off with a question. Symptomatic healthcare workers at UW test positive for COVID, A, about the same rate as non-patient facing staff, B, more frequently than non-patient facing staff, or C, less frequently than non-patient facing staff. What do people think about that?
You're getting a mix of answers, mostly A and C.
Okay, great. So the answer here is actually A, and I'll just share some published experience with you, and there's a lot of unpublished data that we have as well. But this is a study that we did really during our peak surge. And just as a reminder, this really predated universal masking. So this is between March 12th and April 23rd, tested over 3,400. These are all symptomatic employees. So these are staff who have some COVID-like illness and present to our testing clinic for testing. During this time, about 5.3% of all those tested were positive for COVID-19. 6 of those staff members were hospitalized for COVID-related hospitalizations. Thankfully, the ones who were hospitalized during that time recovered. And what's very interesting, you can see the epi curves on the right, is that the prevalence of SARS-CoV-2 when comparing frontline healthcare workers, which includes all of you on this call, compared to non-frontline staff, meaning people who do not see patients, administrators, folks from upper campus, those percentages are really about the same. And I'm thankful that that's the case. And I think many of us have taken that as an affirmation that our infection prevention bundle, not just our PPE, but really our bundle, is helping to keep people safe. So I'll tell you a little bit more about our PPE testing. Let's see. So this slide is just out of date by a few days, but our percentages are about the same. That currently we've tested over 5,500 employees, and our positivity rate right now is about 4.3%.
Hey Seth, can I pause you for just a second? There is a question in the chat. Is the COVID test only valid for 72 hours at all hospitals for procedures, and what's that based on? And then there's a second question after that.
Yeah, so that's a very good question. You know, again, it's valid for 3 days. So if it's, 73 hours, 74 hours, 80 hours, I would still try to accept it particularly if it's an urgent procedure. The challenge with the PCR test, as we'll get into, is it's a snapshot in time. And so I kind of risk stratify people. If you have a low pretest probability and somebody has generally been isolating at home because they know that they have an upcoming procedure, a negative test is pretty helpful because it's unlikely that they're going to be testing positive subsequently. But that's different than somebody who has a high risk exposure who could convert to positive at any time. So if somebody has a high risk exposure, but a negative PCR test, that's one of the reasons why public health and employee health would advocate that person actually be quarantined regardless of the results of the test. But that 72 hours really comes from the CDC. And I would say that's really more at the level of expert opinion rather than any strong data behind it.
Great, thanks so much. And if there are follow-up questions, feel free to unmute yourself and ask the question or put it in the chat. The next question, Seth, is how long is an asymptomatic COVID-19 patient positive? How long is a patient who's asymptomatic but tests positive, how long are they contagious? Or how long can they transmit virus?
Yeah, that's a perfect question. And that's a great segue into the next section of the talk. So maybe I'll put a pin in that for now, and we'll come back to how long are people contagious for. Any other questions, Gabby?
Not right now. I'll keep monitoring.
Daddy.
Okay. So hi, Maddie. So for PCR testing, this is a more recent data poll where we look at this data very, very closely, particularly for resurgence or outbreaks or clusters that could be happening among our healthcare workers. So the day that I polled it, there happened to be one person who tested positive out of 21, so that was a rate of 4.8%. But over the past week, our rates thankfully have been quite low. It's just been 1.8% of symptomatic healthcare workers testing positive. And then, of course, overall, those rates are about 4.3%. And that's much lower than the general UW medicine patient population and even outpatients. So, symptomatic outpatients are still testing positive somewhere between 3 to 5%. So overall, our rates of acute COVID are significantly lower in healthcare workers compared to UW medicine patients in general. Now, we're also looking at antibody testing. And as you know, we rolled out antibody testing in phases. So phase 1 or tier 1 were those folks who directly cared for COVID patients, worked on COVID wards, as well as the emergency department. Phase 2 are healthcare workers in general, and then phase 3 is the UW medicine community at large. And so for UW medicine, I just want you to look at the bottom right-hand corner there where it says % positive for UW medicine employees. So among all UW medicine employees who have been tested, our rates of positivity for antibodies are only 2.1%. And when you subtract out some of the upper campus folks and you just look at healthcare workers, that rate might go up to 2.2, 2.3%, but that's been very, very stable. Now compare that to all of our UW medicine patients or all patients who are being tested in the UW lab, so patients who come from all over the state. Those rates of antibody positivity are significantly higher. And of course, these tests are not being performed on symptomatic patients. These are often otherwise well, healthy outpatients who are curious about their antibody status. So does it truly approximate a random sample of the population? No, probably not. But it still gives us a sense of what community rates might look like. And I think that, in part means a lot of our infection control measures are working, but I also think our UW Medicine employees are kind of a cautious bunch overall, which is good in our line of work. I will say the other thing is that I don't want to paint too rosy of a picture. We of course did have staff who got ill. There were many dark and stressful weeks during the epidemic when we had clusters at sites, across UW Medicine. This is really what I took home from these clusters. And, employee health did a lot of investigating and thinking about what happened here. And I would just say almost all of these infections were linked to staff exposures. They frequently happened in break rooms, or they happened in community settings, particularly household exposures. These, in settings when we had sustained outbreaks, they were often linked to symptomatic healthcare workers who showed up at work. This is also prior to our universal masking policy. And again, this is not to cast any blame at all. I think we were still working through how, from an administrative side, how to best socially distance and trying to figure out our masking policies and other PPE measures. But I think it's really the highest risk times are when staff interact with staff. And it has been extremely rare. I'm not going to say it didn't happen. It's certainly possible that it did. But, just in my role as the director of employee health for all of COVID testing, I am not aware of cases of patients transmitting COVID to staff when proper PPE was used. So it certainly could have happened. I'm just not aware of it. And I just want everybody to know that really the high risk times to think about are really when you're interacting with other staff members. Patient interactions are generally highly controlled. Okay. And then I just want to reiterate that PPE is designed to protect all staff regardless of underlying conditions. And that is truly data driven at this point. Okay, so
Seth, I'm just going to interrupt for 2 seconds. So just on that last point, that the PPE is designed to protect all staff, and I just want to remind folks that within the residency program, if you have any personal concerns about your ability to care for COVID patients for any reason whatsoever, all you need to do is reach out to Kelly and Ken, and they'll work with you. Okay?
Yeah, absolutely. We are happy to talk with people about this, individualized approaches, think about other accommodations. But I also just want to reassure folks that we have many, pregnant nurses. We have many staff, pregnant health staff and others, who unfortunately have been part of exposures. And, our PPE has done a great job, as have all of our other infection prevention bundle in protecting folks who fall into a higher risk category. So talking about exposures, after admitting the patient, you and your intern grab some food and eat next to each other in the team room for 30 minutes. The following day, your co-intern calls out sick, and unfortunately, they test positive for COVID. So which of the following is true? A, this is considered a low-risk exposure, and you should self-monitor and return to work. B, this is a high-risk exposure, and you will be asked to self-quarantine. C, you should get tested, and if negative, can return to work. Or D, you should get antibody testing, and if positive, return to work because you are immune.
All right, we're getting a couple of answers. Give anybody else some time to chime in as well. Everyone's on the same train here so far, which is the B train.
Mm-hmm.
I think all you're getting is B's.
That's exactly right. So let's talk a little bit about our exposure policy, which is new, and it is really intended to keep you and your colleagues safe. And thankfully, we are now aligned with public health. We had not been for some period of time because we really have a critical workforce, and during the surge needed to make sure that we have staff available to take care of patients. But thankfully, contact tracing is now being performed at all hospitals, and we do a risk assessment by public health for reported exposures. So what is a high-risk exposure? In general, this means a healthcare worker who is unmasked for more than 15 minutes and within 6 feet of a COVID-positive source, or a healthcare worker who's present for an aerosol generating procedure with a COVID-positive source, and they're not wearing appropriate PPE. And then I think the other high-risk exposure that we see commonly is unfortunately household exposures with known COVID-positive people. Now I get emails and pages frequently about family members who have a kid who has symptoms and they're wondering whether they need to quarantine. And right now the answer is no, it's really only if the person is a confirmed COVID-positive case in the household, that's when we think about quarantining. So contact tracing at UW, if you have a high-risk exposure as determined by employee health, there are two parts of this. One is you will ask to be tested. And then two, we ask you to quarantine for 14 days from exposure, regardless of the test results. And again, that's because testing in this setting is really a snapshot in time. It doesn't predict whether you're going to test positive in the future. And so there's really no role for testing after a high-risk exposure and then returning to work in most scenarios. And the challenge with contact tracing and these household exposures, and there are a lot of equity issues around this, of course, is that household exposures can result in really a prolonged quarantine if people are unable to isolate from the family. And we in public health can think about ways to help you isolate, particularly if you're in a home where people cannot just go to the basement and isolate or be away from family members. But oftentimes this may mean that you may have to wait for the duration of that family members or household members infectious period. And then the clock starts for that 14-day quarantine. So that can be a long time when people are actually out of work if they can't be away from that household member. Healthcare personnel who are low risk can self-monitor and return to work. And this, the risk-based approach that we take is based on the CDC. And I would say it works pretty well. I would say people who have low risk exposures really, truly do have an extremely low risk of converting to positive, and I'm not sure we've really seen that happen. So just a reminder, you are all superstars, but we also don't want you to feel like you should be a hero. And so if you have symptoms, we really want to make sure that there's a low threshold for you to get tested. And self-monitoring will help you and your colleagues stay safe. So when you sign that attestation in the morning, it's not just signing your signature. We really want you to take that as a moment to be mindful and check in with yourselves. And if you feel like there's something off, if you feel like there's a new symptom coming on, have a low threshold to call out sick. And I guarantee you that your co-residents, your chiefs, your program director, your attendings will support you. Your infection prevention and employee health teams will support you, and people will thank you for keeping everyone safe. And again, that's the link to the testing survey.
Hey, Seth, I'm going to interrupt for just a second for a chat question, and this is related to residency-specific policy, I believe. So the question is, if we have to do a 14-day quarantine for COVID exposure, does that time get pulled from our sick leave and some other bucket? We've had a number of residents who have had this experience, who have not tested positive but have had a high-risk exposure. And for the quarantine, I am almost positive it does not get pulled from your sick time. You work with Kelly and Ken, and Kelly and Whitney will work with you to figure out a plan. And I'm almost 100% positive that does not get pulled from your sick time as a resident.
Yeah, that's correct. And of course that. Okay. Yeah, and of course that, that piece of it doesn't come from infection prevention, it comes from, human resources. But we have lobbied very hard, and human resources is supportive that particularly any exposures that happen at work are not coming out of sick time. I mean, that is paid leave because that is an occupational risk. Community exposures are potentially a different story because it's not necessarily, occupational. And that's something that I would encourage you to work with Kelly and Ken and HR about.
I think for community exposure, everyone, while Seth is talking, I'll try and find Kelly's most recent updates. I still think for you all in the residency program, I don't think it comes from your sick leave, but let me look that up while Seth is talking, and I'll get back to you.
Okay, so now the patient's test comes back positive, and the patient's entire extended family proceeds to follow him upstairs. And you explain to the family that according to the UW visitor policy, A, only one visitor is allowed for most non-PUI COVID patients. B, patients with COVID are not allowed visitors unless at the end of life. C, visitors must always wear masks. D, visitors under 16 are not allowed. E, visitors who refuse to wear a mask will be escorted out of the building by security. Or F, all of the above. Gabby, let me know if there are any.
Yep, sorry, I was going back to the residency policies. F is what you got.
That's right. So F's the right answer. And I would say, I think we're struggling with this. I know that as providers, we are not used to confronting visitors or trying to figure out how best to interact with them and involve them in patient care like this. But I would just say there were really 2 times during the epidemic when my heart was truly broken by policies. And I would say one, the first was when Seattle Public Schools closed. And the second was when we stopped allowing visitors to come to the hospital altogether. And it was incredibly painful, as many of you also experienced this, to watch our patients go through their illness without a family member or a visitor present.
Sorry, why are those under 16 not allowed?
That's a very good question. I'm not sure I know that all the answers to that, but children in particular, they have difficulty wearing masks, and often they need to be accompanied by an adult. So just in terms of limiting the number of visitors, we usually say it's one adult visitor. As I was mentioning, it's very difficult for patients to experience illness alone. But I just want everybody to know that visitors must wear masks at all times. There have been situations where it can get very contentious, where a visitor, for political reasons or other reasons, does not want to wear a mask. And we have, for the most part, successfully diffused those situations, and you can offer face shields to help de-escalate things. But I would encourage you to read the visitor policy, both to help visitors and patients with their questions about it. But also, we are really trying to create this culture in the hospital, this culture of safety. And so if you see folks in the hallways, the cafeteria, and patient rooms not wearing masks, I strongly encourage you to speak up and say, this is really our policy. When you're in our facility, we need you to be wearing masks. We have a lot of high-risk, vulnerable patients here. And again, you can find the policy at our one.uwmedicine.org site. Okay. So your patient is febrile and setting 94% on 1 liter. What treatment is currently recommended? And I'm going to just go through this section relatively quickly, but do people want to give dexamethasone, convalescent plasma, remdesivir, tocilizumab, supportive care, or F, I should probably look this up?
Getting E's and a couple of F's.
Yeah. So these guidelines are changing incredibly quickly. And I would just say looking it up is probably a good thing to do every week or two. The most updated consensus document is on that SharePoint site. There's also a separate treatment site, covid.idea.medicine.uw.edu, which tries to keep up to date with all the evidence behind treatment, also has slide sets and other things if you're giving a presentation on this topic. Right now, this is what the current recommendations say, though I suspect this will be out of date soon. In general, people with mild illness should get supportive care. The only points that I want to make are, points of confusion are for dexamethasone. The recovery trial stopped steroids when people were ready for discharge, and so we should be doing that too. And the same thing with remdesivir. If somebody is ready for discharge, you do not need to continue dexamethasone or remdesivir or keep them in the hospital for additional treatment. The other points to make on this is that our remdesivir allocation is really beginning to run low. And so you may have noticed that patients this week who may be requiring low rates of supplemental oxygen have not been approved for treatment, while similar patients were approved a few weeks ago. And so if you think that your patient is going to be likely to discharge in the next 1 to 2 days, I would say probably don't request remdesivir. Otherwise, continue to let the allocation team do the work of deciding who should get it in a blinded manner. Again, there are some numbers there, and there are links to the REDCap survey for remdesivir requests on the main website. Okay, so fast forward 7 days, your patient is feeling much better, and he asks, how long do I need to self-isolate, and when is it safe to see you in clinic, since you are now my new primary care physician? And the possibilities are he needs 1 negative test, he needs 2 negative tests, he can return to clinic without precautions after 10 days if symptoms have improved, or he can return to clinic without precautions after 20 days if symptoms have improved.
Okay, go, sweetie. I'm waiting to see if folks have thoughts. All right, I think that we're getting mostly C, but definitely question marks on this one.
Yeah, so this is something that is in evolution. Right now, this patient can return to clinic without precautions after 10 days if symptoms have improved. And this is because the CDC just published new guidelines, and we at UW Medicine are in the process of adapting these guidelines. But overall, we test way too much. And I think, as all of you have experienced, overtesting leads to care delays, inappropriate PPE, what feels like unending isolation for patients. And so patients, there's a good evidence base now that patients with mild to moderate illness, which is often defined as a SAT above 94%, and are no longer contagious. Sorry, these patients are no longer contagious after 10 days if they're symptomatically improving and they're afebrile for 24 hours. And that time point is really at that 10-day mark. It's not that if they started with more severe illness, but if they have mild illness at that 10-day mark, then they can safely be de-escalated in terms of isolation precautions. The CDC hedges a little bit that patients with severe or critical illness may be infectious for longer. Most of the data would suggest that at most they're infectious for maybe 10 to 14 days. But to be on the conservative side, we're putting those folks closer to the 20-day cutoff for discontinuation of isolation precautions. SCCA patients may be a carve out for this policy, and so we're working on that now. But for solid organ transplant recipients and for other folks who are on the general COVID wards, we can say that 10 days, and if the symptoms are improving, we can start to de-escalate precautions, and they can safely be seen in clinic.
Hey, Seth.
Yep.
Just clarifying, are these days since symptom onset?
Yes, thank you. Since symptom onset. And going back to that question about asymptomatic patients, that 10 days also applies, but of course that starts with when the first positive test was. So I'd just like to make a deal with everybody, and it's okay if I don't take it personally if you've been tuning out for the last few slides, but I'd love everybody to just tune in, because I think this is really the most important part of the talk, which is that if we all commit to meticulous PPE technique, hand hygiene, self-symptom check-ins every day, and being mindful of what's going on with your body, being mindful of high-risk times such as eating or drinking together within 6 feet in team rooms, break rooms, the cafeteria. If we all continue to socially distance in the community, and if we remind visitors, staff, and outpatients to wear proper face coverings, then we get the payoff, which is all of you get to go home feeling safe. You should all feel guilt-free. You should not be worried about spreading COVID to your loved ones. And really, you should have that peace of mind that you will be safe at work. And so please let me know if you agree. Feel free to type it into the chat. I just want to make sure that we are all on the same page with this, that if we all sort of buy into this bundle, we are all going to be safe together.
I think you are seeing folks coming together in support of this deal.
Okay. All right. Well, thank you, everybody. And I'll just add that if COVID wasn't bad enough, many of us are dealing with new dermatologic conditions. So there's something called maskne, which is probably due to just increased skin irritation and increased skin moisture. And I would just say, be gentle to your skin. If it really bothers you, you can try salicylic acid washes or benzoyl peroxide. And we can also work with you to try to find hyperallergenic masks if you're really having a severe dermatologic issue. And then, of course, just to close, we don't care how big your nose is. Nobody wants to see it. Keep it in your mask, please. And just remember good hand hygiene and masking technique. So in summary, there's still a lot that we don't know. We support you. PPE is designed to protect everyone. We really do feel like our policies will keep you safe, and these policies will continue to evolve, and that we are all in this together. So thank you very much, and I'd be happy to take questions.
Thanks so much, Seth. All right, everyone. I'm keeping the chat. Okay, Madeline, can you be quiet, please? Thanks for bearing with us this morning with with our special friend here. So Seth, there's a question. I fielded a lot of questions from patients about the efficacy of cloth masks and the risk of fomite transmission. Any resources that you recommend sharing with patients, or a spiel that you have that you would recommend?
Yeah, the CDC, it's very interesting. So several weeks ago, the CDC really backed away from fomite transmission as a major mode of COVID transmission, which is interesting because many other respiratory viruses are transmitted through fomite. So I'm not exactly sure why they would say COVID can't be. I mean, clearly we're not seeing it as a major mode, but I still think, cleaning high-touch surfaces in other areas, seems very prudent in our workspaces and at home. Cloth masks provide, significant benefits both for protection and acquisition, both for transmission and acquisition of the virus. They're probably not as good as surgical masks, but they go a long way. And so I would just say look at both the Washington Department of Health website as well as the CDC for recommendations on that. And there's also some just nice infographics that are floating around, but there should be some handouts on those sites about masking for the general public.
Awesome. A couple other questions. Could you review treatment indications with remdesivir and dexamethasone? You mentioned O2 sat less than 94%. Is this also off oxygen? I thought the recovery trial included those using supplemental O2 more than 3 liters. And
yeah.
Another question after this.
Yeah, it's usually folks who are on supplemental oxygen with an O2 sat less than 94%. With remdesivir, it's hard to, it really depends on our allocation. So that's why there's a whole group that's working on it. And I would just say I'm not sure that I can give you the indications off the top of my head because they change so frequently. And I would just encourage you, I think the document was updated a day or two ago. I would just encourage you to just pull that up on the UW Medicine site under treatment guidelines, and you can see pretty clearly what it is. Of course, it's still given in a blinded fashion.
Okay. It sounds, okay, first of all, I'm just gonna address this. Seems like the QR code is for attendance. So if people are having trouble with the evaluation QR code, I apologize. I was perhaps sent the same one twice, and I will make sure that I send the evaluation code in an email to everybody. The next question in the chat is, what's the utility of getting antibody testing? Folks are going back and forth about it, not really sure what I would do with the results.
Yeah. I had the exact same reaction. Because I helped set it up, I got my antibody checked, but I'm not sure that I would have otherwise. I think, it's really only useful at a population level. We want to know how many healthcare workers have been exposed. And I think for that reason, I would also, really want to know how many house staff were potentially exposed with or without knowing it. But on an individual level, it's very clear that we just don't know whether this correlates with immunity. This would not change our PPE strategy if you had a positive antibody or not. And we've seen people who have positive PCR tests but negative antibodies, or the converse, negative PCR tests but positive antibodies. So I think we're still learning what clinically a positive antibody means.
Great. All right, I'm not seeing any other questions in the chat. Feel free to put questions in the chat or unmute yourself if you have questions. Otherwise, I will say thank you to Seth so much for joining us this morning and providing this overview. I can personally attest to his approachability, and I know that he's always happy to talk to our residents and interns. You'll see him throughout residency doing a whole bunch of non-COVID ID teaching, which is really fun. And feel free to reach out to him if you need to know how to get in touch with him. Just get in touch with me and I'll put you in touch with him. All right. Thanks everyone. I'll keep the Zoom open just in case folks have questions, but otherwise have a wonderful day, and I will see you next week.